everyone. Welcome to the afternoon session of our symposium. My name is Lori Markey-Potvin. I'm the director of the Pathways to Excellence program with the Coalition. My first order of business is to try to get some of you that are in the back of the room to try to move forward a little bit if you can. We try to want to make this inclusive, and we want people coming to sit up front, or the people that are just walking in can come sit in the front. Because that's what we do. Thank you will. Thank you. Thank you. Okay, so for this afternoon's session, we're going to be talking about making shared decision making a reality in your practice. The session is an hour and a half long, so it is a bit long, but that we wanted to make sure that everybody got time for questions and answers at the end. And so our speaker today is Dr. Wexler. He's the Chief Integration Officer for HealthWise. It's a global provider of health information, decision support tools, behavior change assistance, and personal care planning for health plans, care management companies, hospitals, and consumer health portals. And in his spare time, quite a bit. In his role at HealthWise, Dr. Wexler maps the course that connects HealthWise solutions to the provider market. Before joining HealthWise, Dr. Wexler held a leadership position at Health Dialogue, where he focused on health coaching and provider programs. He maintained an active medical practice here in Maine for the 12 years after training at Johns Hopkins, the University of Vermont, and Harvard University. So one other note I need to make before we begin is Trevor asked me to remind everyone that if you are interested in CME, HR, or broker credits, they are available for participation today, and you can get what you need to register for those down at the Coalition table after the session today. So please join me in welcoming Dr. Wexler.
Well, thank you. And please, if I trail off, I know it's afternoon, and you can't hear me in the back, let me know, okay? Well, it's a pleasure to be here, and I'm grateful to come and talk about something that's near and dear to my heart, shared decision making. I thought I would just take a little moment to talk about my personal experience as a physician practicing in Maine, and that was sort of how I got interested in changing the system. And I ended up now in my career, after working some 25 years in quality improvement initiatives in general, focusing a lot on shared decision making, which we'll get to. But I came to practice in Maine as a gastroenterologist a long time ago, 1981. It's hard to imagine. And so I joined a group of 3 others, and I was not really quite sure how the group was organized, but we had a nice few initial meetings, and it seemed like a good fit, and Portland was definitely a place I wanted to be in. So got there, and then I realized after I was there for a bit, having trained not only in gastroenterology, but done a year's training in psychosomatic medicine, because I knew that the mind and the body were connected, and it often got expressed in the digestive system, that would be an important aspect of how I approach patients. So when I learned that our reimbursement system in our group was basically revenue less expenses at the individual level, we were an expense sharing group. And my partners recognizing they have many wonderful qualities, but they also recognized that I had this special training in mind-body medicine and functional bowel disease and really challenging situations to handle. I got known as that kind of specialty provider amongst my provider partners. And what that meant was that I freed them up to do a lot of procedures, which is what GI came to be all about. Now I'm glad I didn't go down that path. I can't imagine having spent 25 plus years doing colonoscopies. Hard to picture that as the best use of my curiosity and my time, but nonetheless it hurt me that they would be making significantly more than I do. And so there was a payment reform issue right there, and I said, this is not right. And so after trying to convince the group to change their reimbursement model, having no success, because one of the rules of nature is I think that your expenses grow to meet your income, and nobody wants to take a decrease in income, I left the group, and I practiced for another 6 years on West Street. I don't know if those of you who know the Portland area, but it was a federal-style home. I had the first floor. There were 2 fireplaces. There was a chandelier. And the one person in my office that I worked with in the first 6 years came with me for the next 6 years. And it was just the 2 of us. And it was a very rewarding experience for me as a physician, because I really knew my patients, and the whole setup was conducive to understanding who the person is that has the illness that you're dealing with. And not only did I know that, but Corey, who worked in my office, did all the transcriptions at that point in time. So I would dictate a history, and she would transcribe it into the paper record. She knew everything about the patients as well. So when they called up, we knew who they were, and we were ready for them. And that's what I've heard as a description of a medical home. We know who you are, and we're ready. So I realized that was a really privilege, not only for me, but it's a wonderful patient experience. But my mind got going into, well, I really want to do other things to make the system work better. When that really struck me was, I had the whole vision of the many years of colonoscopy in front of me, and deciding that wasn't quite right, but there was an issue that was coming up about how to treat bleeding ulcers in your stomach or the duodenum. And if there was a visible vessel, how would you treat that? A vessel would be like a millimeter in diameter, but you could see it through an endoscope. And it was fascinating, you could. I was going to these meetings in GI meetings in San Francisco and went to sessions. Well, how do you cauterize that? There are trials about this. Do you do 4-quadrant cauterization? You go around it, and then do you zap it in the middle, or do you start right on the vessel and then go around in the perimeter? So there are trials about this. And I was coming back and I said, this is not all that interesting to me. I think we're not seeing the big picture. And that's where I started, with wanting to see the big picture of the patient. So that's why shared decision making, for me, is such an important topic. And I hope it's one that's of interest and that you will find worthwhile trying to promote in whatever roles that you play. Let me stop and then just get a feel of who's here. So I don't even know the best categories, but I'll start by how many physicians are in the group. Thank you. And how many nurses? And how many patients that aren't also nurses and physicians? And how many practice administrators? And that's a good start for me. And those who didn't raise their hand, what do you do? Hospital administrator.
Employer.
Employers.
For a client.
Or for a client. Yes?
Physician assistant and PA educator.
Great. Great.
Patient partner and advocate.
Terrific. Okay. Well, good. I think this is going to be a friendly audience, and I think there will be some traction. How many people feel that they have a pretty good understanding of what we mean when we say shared decision making? Just raise your hand. Okay. That's good. So we got that as around 2/3 of that. Now, how many are working in a setting where you're actively trying to make shared decision making a reality? Great. So I'm glad there's a good match for this workshop for the number of you who have interest. So much of this it's going to get kind of tactical, but I don't want to start at that tactical level. I really want to start at the big picture level, because what we're talking about is really fundamental. It's very fundamental change in the way that patients and providers interact. And we can put it in the context of a quality improvement initiative, but it can't be relegated to like the importance of managing A1C or your LDL levels, because it is much more fundamental than that. For the few minutes before going around, I was walking around before coming in today, and I was saying, well, what would be analogous? And well, it's behavior change, so it's sort of like, we heard about washing your hands. But it's quite more complicated than washing your hands. But we know how long it took to get people to wash their hands in healthcare settings. it's fundamental. Maybe it's sort of like implementing electronic health record. And then I started thinking, boy, look at all the money that has gone into that, and how much difference has that made yet, or in the long term, open for question. What if all of those resources that we had put into the electronic health record were really, at least a tenth of them were put into promoting a new way of providers and patients interacting, developing training programs, developing models, developing measurement strategies, thinking about incentives, promoting it in the population so we could have patients demanding it, we could have practice and hospital administrators saying it's important to us. We could make this happen. And so part of the catalog or the flyer that I saw says most studied and underused intervention, but I believe it is within our grasp to make it happen. It just has to become a priority. So with all of that, I'm going to talk, I put two slides together, just, I rearranged a bunch of other ones and added to, I got two new ones for today, and I'm not exactly sure how well they're going to work, but I knew it was coming back to me, and I can try them out, so here they are. So this is really about changing roles and relationships, shared decision making. And I was looking for figures, and I know there's real danger to having this being a physician or clinician, but for now, please accept that. And this is the patient. But what do you notice?
No face.
No face. Faces. Yeah. And that's part of what we're changing. It's really seeing each other as real people and interacting as real people with an interest in each other, each with unique skills. So this is like the transformation. This is taking off the mask or the white coat for the clinician. This is saying, you know, it's all right for you not to be all-knowing. True that in your training, everything was about mastery of information, but you can't do that anymore. It's okay not to know everything. You can look it up. You can say you don't know it. You can be human. You can be curious about your patient. You can be empathic about your patient. And I think that's the experience and joy of medicine that we talked about earlier. If we can do that and return it, it will be something quite invigorating for clinicians. But why has it dwindled so much? I think that the tyranny of tasks has gotten in the way of feeling. That's the besieged primary care and specialty care providers. There are so many things on the checklist, you don't have time to feel. And without that, it's very hard to build an empathic connection with the patient. That's part of the shared decision-making experience. And because of the white coat authority figure, patients are afraid to speak up. That's well studied. They're concerned about being labeled a bad patient. If they express their opinion, if they ask questions about what are my options. So imagine a day when the mask is gone and the patient feels free to express all the uniqueness that makes that patient a person as it relates to the healthcare situation that they're discussing at that moment. That's the kind of environment that we need. That's the kind of change that we're talking about. And from a patient experience perspective, I believe that for many patients now, they feel alone and they feel like they're down on a single rail, a one track. They don't understand what their options are. So imagine that we've changed that. And there's lots of light, there's lots of people. And this is the station. They can buy a ticket to where they want to. They know what the schedule is, they know where the trains are going. And they can hop on the one that's right for them. So how were those two slides? Starting, setting the scene. Okay, well thanks, because I'm going to get much more tactical now. I'm going to take a couple of slides just to talk about what is shared decision making and what are patient decision aids. I'm going to do one thing first. I'm going to frame this in another way. I'm going to frame it as a patient safety issue. And I think this is a strong framing of the importance of shared decision making. When we think about the worst kind of medical error, the kind that gets in the newspaper, on the television, what is it? Killing a patient. Yeah. Killing a patient. That is the worst, but that often doesn't get in the newspaper, right? But a wrong site surgery does. If you operate on the wrong limb, the wrong side of the brain, that is a tragedy. And we know the precautions that we have taken as systems now to be sure that's not the case. But what would you call it, or how do we describe operating on a patient who would say no to surgery if alternatives, risks, and benefits were well understood? And we call that wrong patient surgery. And it's a bigger circle by far than the wrong site surgery. And again, imagine what it would be like if we had systems in place to guard against wrong patient surgery like we now have in place to guard against wrong site surgery. So I'm going to do a little bit of level setting in terms of what is shared decision making, what are patient decision aids. Then I'm going to give an overview of implementation with a model that we've had a chance to develop while working with provider groups around the country who have been doing this, and we've been meeting for now 6 years in a learning collaborative. I'm going to then have a couple of scenarios where I will ask the audience to participate in how you would design a program to meet a specific clinical scenario. So there's going to be some participation to keep you awake and going. And then if we have time, we'll have discussion and next steps, okay? So that's the plan. So there are lots of definitions of shared decision making, but I particularly like this because it is a process, first of all. It's not a thing. It's a process of interacting. It's a conversation, really, a series of conversations with patients who wish to be involved in arriving at an informed, values-based choice among two or more medically reasonable alternatives. They are informed, first of all, that there is a choice, because oftentimes they think things are pretty black and white, that there isn't a choice. They know what the options are of that choice and what the benefits and harms of the options. And values-based choice means that all of this information over here is viewed through a very personal lens that's shaped by the goals and concerns and the unique life circumstances of the patients, because they will value the options quite differently depending on what's important to them. And the process is this bi-directional flow of information that can occur in a face-to-face or a virtual conversation where the clinician is the expert on the options and the benefits and potential harms, and the patient is the expert on themselves. And they exchange information to allow for a shared decision-making experience for conversation. It sounds simple, and people would say, well, doesn't that already happen? And if we asked in polls, if I do this with physicians, and say, do you already practice shared decision-making? Usually around 70% will raise their hands. But if you do any sort of explicit evaluation of that, we see that it really doesn't happen. So we have to present this as, well, you are on your way, but we will try and do what we can to allow you to make it better and easier for you to do it. And one of the ways to make it easier is to break it down into steps, get a schema for it. And these conversations are going to be organic. So they're not going to follow a 6-step routine, but at the end of the conversation, you should check in and say, have I covered these? Invite the patient to participate. That invitation is so important. Even if at the end of my career, that's what was happening, patients were invited to be participants in the decisions because their life, their goals, and their values were important in many situations, that would be a huge step. Present the options, provide information on the benefits and the risks, assist the patient in evaluating the options based on their own goals and concerns, facilitate deliberation and decision-making, and then this last one can't be forgotten. I mean, it doesn't end, right, when the patient leaves the care setting. Help them with the implementation. And, you know, when I present this, everybody in the clinical world immediately gets concerned that I don't have nearly enough time to do this. And I certainly can't do this about all of the decisions. Heck, in one 15 or 10-minute visit, I may make 10 decisions with or for a patient. So how am I going to do this? Well, first off, I'm going to say it doesn't have to apply to all categories of care. And I don't know how many are familiar with this distinction between effective care and preference-sensitive care, but in effective care, there's a very strong evidence base that it works. Our goal is to increase the uptake of that, and that's where we have motivational interviewing is really a non-directive but directional approach, trying to increase the uptake of what we know works for nearly all patients. Healthy lifestyles are examples, certain medications are examples. Contrast to preference-sensitive care, where the evidence supports more than one approach, treatment and testing options involve trade-offs, and personal values, preferences, and life circumstances should really drive the decisions. The informed preferences and values, so they have to have the information about the options and the risks and the benefits before they come to a decision. This is the sweet spot for shared decision making, and there are tools to help. Patient decision aids. How many in the group are familiar with patient decision aids and use them in the clinical setting that you work? We got 2 or 3 people. So that's a good start, but this is part of our challenge. We have to figure out how to make these accessible, integrated into the workflow, and help take much of the routine flow of information about options, risks, and benefit out of the visit, so the visit time can be used for what's more important, that discussion. It's sort of like the Khan Academy approach. In a way, you do a lot of the teaching out of the classroom, and then you have the discussion and do the homework inside the classroom. So there are tools to facilitate shared decision making, and implementations. Often in the beginning, everybody focuses on the decision aid. How many did we get out? And we do counts, but nothing on the conversation, because the conversation is really the hard part. That's the behavior change, and that's a much harder part. And the shapes and sizes, I'm going to show you some in a minute, but they come in all shapes and sizes. So the minimum standards to qualify as a decision aid, they describe the condition or problem. They explicitly state that the decision needs to be, what decision needs to be considered, describes the options available, describe the positive features of each option, describe the negative features of each option. And this doesn't happen in conversations or what patients hear about conversations. We tend to sell and not talk as much about the negatives. And describes what it's like to experience the consequences of the options. We try to, there are tools to help patients imagine alternate futures in a realistic way. Unlike marketing campaigns, which are trying to sell you a perceived alternate future if you buy a particular car or perfume or watch or something like that, this tries to be much more realistic about the alternate futures, so you can think ahead a little bit. They're a subset of educational material patient decision aids, but they are only that. Much education material doesn't qualify as a decision aid. So they're geared to a specific decision. So educational materials are not geared to a specific decision. It's materials that advise people to choose one option over another. Like the choosing wisely material, that's about ineffective care, and it's about how to discourage choose. That is not a patient decision aid. Materials designed to promote compliance with a recommended option, that's not, nor is a passive informed consent material. Informed consent is an interesting other discussion, and many people think that if you're able to have a shared decision-making conversation supplemented by decision aids before the decision is made, that's a perfected form of informed consent. And there's some interesting action now that if you do that in the state of Washington, you get a higher level of protection against malpractice. If you want to get an overview of the types of decision aids that are out there, you can go to the Ottawa Hospital Research Institute. This is their site down there. They have an A to Z inventory of patient decision aids. And things, when you see this, there are things to check. When was the last update or review? Because these are hard tools to make, and they're even harder once you make a bunch of them to keep them up and current with the evidence. Some of them are freely available in the public domain, and others are commercially available for a fee. And there is a set of standards, the International Patient Decision Aid Standards, that have been scored, that use to score different decision aids, and you can get the scoring of that. There is no minimum score required to qualify by IPDAS standards yet, but a lot of work is going on around certification, again, at the at the state level in particular, in Washington State is leading that. The concern is that there could be biased material masquerading as unbiased material to promote certain treatment options. And that's why some certification seems appropriate. And if we're going to change incentives and actually affix some dollars to using decision aids, we want to be sure that we're using unbiased tools. So I'm going to just show you some photos of different decision aids. I worked, as mentioned in my intro, at Health Dialogue, and I was previously with the Informed Medical Decisions Foundation before we merged with HealthWise. And we, for many years, used DVDs and booklets for particular topics. Now, much of this material is also available online, but it's interesting. A lot of people still want paper. And although the DVDs are sort of long, around 30 minutes, and that seems like a really long time today when you have an internet experience, it's not that long when you sit down on a sofa and put it into a DVD player. So the expectations vary with the format. This is an example of a decision point that is made by HealthWise, my employer. And it's sort of simplified with 6 steps that you can see there. You click your way through, and you get a summary report that you can print out that you can take into a clinical setting if you wish. This is from the NCI. It's a really good decision aid that references colorectal cancer screening, and it's sort of pro-screening, but talks a lot about the different options for screening. So it's not a decision aid too much in terms of should I get screened, but what are my options to be screened? And this is one from AHRQ on urinary incontinence. So if you search around, you can find some are at no cost, and some there's a bit of a fee for them. So this is the hard work, right? Making it happen, implementing shared decision making in various settings. And if we think back to the beginning of this, really fundamentally changing the nature of the interaction, we have to expect it to be hard. It is a fundamental behavior change. So it's a ride. There are going to be bumps in the ride. But if we think about how important a transformation it is, I would suggest that it's a ride worth taking. As you think about implementation, there's a decision to be made. You can do it, of course, in an integrated delivery system, as we're moving towards. But even within that, are you going to focus on primary care? Are you going to focus on specialty care setting? Or are you going to focus on both? And of course, the topic that you choose, the decision you're supporting, will have a lot to do with whether it's going to occur in primary care or specialty care. But that's an early decision. If we think about primary care implementations in general, they seem to work well when the test or treatment is managed in the primary care setting. Well, that's kind of obvious. But if you think about which ones, screening tests, and certainly colorectal cancer screening and PSA testing for prostate cancer screening are good topics for shared decision making. Works when the whole care team is involved. So don't think that all of this conversation support has to occur with a physician. Sometimes that's probably the most appropriate setting, but certainly not always, and that's up to the organization to decide. There's a lot of variation about how much you delegate authority for decision support and actually helping people make decisions. So sometimes the support might be preparing for a visit with a physician where a decision will be made. Sometimes it is support that allows the decision to be made and implemented, like having a blood test for prostate cancer screening, or what kind of colorectal cancer screening you're going to have. So sharing the responsibility makes a lot of sense. It's important to know the diagnosis, really important to know it. So pain is not a diagnosis. Back pain is not a diagnosis. But if you know the diagnosis and surgical consultations are being considered, this is an ideal situation for shared decision-making in a primary care setting to give a patient an opportunity to look downstream and see, do they want to step on that swift current of care, or do they need a little more time to understand what all of their options are? And even if they want to proceed further, when they get to the specialty care visit, they will be better informed. And we have some information that the visits with the specialists will be more rewarding for the specialists and for the providers, and for the patients rather. And of course, aligning financial incentives. So all of this takes some cost and infrastructure. So if there is some way to make that affordable at the practice level, that's a good idea. Even using time-based codes for a shared decision-making conversation with a physician is a fairly reasonable thing to do, though the challenges of that are that they're relatively under-reimbursed because we don't value time enough compared to other visits. Specialty care implementations work well when wait times are long, because then you can make sure that the patient, if they've had a chance to understand what they might be signing up for, and again, it's on average information, so it will need to be tailored at the visit. But they may say, well, I'm not ready. I had no idea that the risk was that. Or I hadn't tried this, and I think maybe I would rather try this first. So they can get out of the line and maybe get back in the line later. In a fee-for-service world, where specialists are often worried about a decrease in the income, if you shorten the wait line, you don't actually diminish the throughput, you improve the service. So in fee-for-service world, if you have a long wait line, that helps deal with some of the resistance that you encounter. The reason for the specialty consultation, well, I skipped this one. Non-operating clinicians perform triage. We're seeing more and more of that. I don't know how many of you do that in your practice settings or are aware of that, but we see that where there will be a physiatrist that would be in an orthopedics office or in a neurosurgeon's office for back pain consultations, and they can be involved in making sure that the patient has gotten a decision aid and gone over that with the patient before the patient sees the surgeon, if indeed they want to see a surgeon. The reason for the specialty consultation is clearly defined at the time of referral. That's, it makes a lot of sense sometimes to put decision aids in place before a visit is made, so that it's sort of homework getting ready for the visit, pre-visit work, I guess we would call that. But it's really surprising how bad the information is about why the patient is coming in the first place. And so if you don't have that information, it's hard to get the appropriate decision aids out to the patient in advance of their visit. And then again, financial incentives being aligned. So in fee-for-service world, there's a big concern that this will decrease volume, that fully informed patients will opt out of more aggressive procedures and try more conservative. And I can take just a minute to talk about that literature because it's intriguing to a lot of those as we're trying to improve the quality of care and manage the cost of care. Because this could be a win-win in a way if we're not operating on the wrong patients. But that literature is pretty thin. And when we trot it out, there are some good questions that are raised. Well, what was the cost of the alternative treatment? What was the baseline surgical rate in this population? How long was your follow-up? If you say it saved money in the 1 year, what happens in 5 years? Do they come to surgery eventually? So there are a number of issues with that. So I see it as intriguing information, and there are many people who have a more aggressive view about the value of shared decision-making and cost saving. Lots of barriers, but as I said, if we put our mind to it and we create appropriate levels of importance to making this happen, I believe that we can overcome them all. So there are many provider misconceptions. The belief that they're already doing shared decision making, that's a common one. Patients want me to decide and they won't understand the information. I'm not showing you this information because this is more around implementation. We have tons of information. That's totally wrong. If patients understand the role, if they understand that we're not asking them to be the technical expert, but we're rather asking them to be expert about themselves and what is important to them, and to share that information, the vast majority of patients want to be involved. It takes too much time. Well, a lot of that happens to be affected by how you implement, how you use the team, and how you run your visits anyway. If you just tell the patients what to do, and now you're suggesting I'm going to have a conversation about what the options are, that will take a little more time. It's hard to imagine that it wouldn't. But there are ways that you can do this that it doesn't take much more time or any more time, depending on the type of consults that you're doing. This concept this morning about we have to focus with all of them, and it came out of the 600 or 400 quality metrics. Why don't we focus on what's really important? And we overlook the obvious like this, I believe. So we have to make room on the shelf for this initiative because it's so fundamental. The lack of IT infrastructure and easily available DAs, so there's a big movement now to integrate these into the electronic health record, make them one click away and easy to do, or to automate the delivery, link it to a referral process, link it to a population-based approach. There are ways to do this that don't rely only on physician memory to accomplish it. But this is an emerging infrastructure to support this and to document the conversation. Training, I mean, many of us have had some training that's relevant to good communication. A fair number of us haven't. So introducing the concept and some of the techniques is an important step if we want providers broadly defined to participate. And for patients, if we want them, we need to give some training to patients about how to be active participants in a conversation during a visit. We've talked about the lack of reimbursement, not knowing the reasons. And this one, not knowing the numbers. If you're supposed to give the pros and cons of the options, it's not surprising that those numbers and how to communicate those numbers in an effective way are not on the tip of the tongue of all the providers. So we need to say that's okay, that's part of taking off the mask. And if we have a decision aid, at least that's a starting point. And if we don't have a decision aid, I'm going to say this is my best estimate of this, and I will go back and research if it is something that's important for us to do. But people are fearful if they use decision aids that the patient will know more about the options than they will be, and they will be called unknowing. And for a physician to be called unknowing when so much of the mastery and getting ready was about knowing the numbers, mastering the literature, it's a very embarrassing situation. All right, so this is an overall schematic, and I'm imagining from the back, I'll just walk back this way for a minute, see how that looks, that it's not that easy to see. I'm going to read it as we go. So again, we are calling these 8 steps to success for implementing. And they're not exactly linear, and they're not exactly rocket science, but it takes a discipline to think about these all as you're thinking about implementing a complex intervention, particularly one that relates to something as significant as behavior change. We'll go into a number of these in a bit of detail, and then we're going to do our exercises where we're going to have a couple of clinical scenarios, and we're all going to figure out the tactics that we use. But it starts with engaging anybody that really touches the project. So they have to be engaged in this project. Then, as we're thinking about this, we have to figure what is the population of patients that we're targeting, and when in the course of their illness are we targeting them? How are we going to identify that targeted group? How are we going to distribute the thing, the decision aids, to patients at the right time? And I call this out, how do we encourage their use? Because they get so much stuff. We have to create some reason for why it's important for the patients to access the material that you distribute. How do you support them in the shared decision-making conversations? How do you measure the impact? And then how do you provide feedback? So they're all pretty logical steps. As I said, I don't think there's anything too special about it other than the discipline of thinking about all of these and developing checklists for these steps, and really remembering that you got to work these all into a project plan. And I'm just going to talk now about some of these steps and give you some of the tips that we picked up in our work with practices. And I'm a student of motivational interviewing, so I think it applies at the individual level, at the organization level, and I learned mostly about it, raising my kids. And it's hard, I make a lot of mistakes still. But if I break it down and I think, the motivation is really the sum total of something feeling important to me and feeling confident that I can do it, then I'm more apt to be motivated to do it. That doesn't mean it doesn't compete with all the other conflicting priorities. But if I'm really going to motivate this at an organization or at an individual level, both of those feelings of importance and confidence need to be there. And some of the tips, I think clinicians generally want to improve the quality of care. So we have to present this as a really fundamental quality initiative. At an organizational level, we have to get some focus. It has to become a priority at the organization, and we could have a whole discussion about why that might be. Why would an organization make it a priority? And so from the leadership all the way through the organization, it has to be known and felt as a priority. We have to encourage, for it to feel important, we have to encourage patients and their caregivers to be involved, because part of this is going to be a push from the patient side of the equation. And we have to continually to invite them. We need to have physician champions and provider organizations. They have to believe in it and feel that this is the right thing to be doing. Without a physician champion, even if you have executive sponsorship, it's not likely to be a robust implementation. And for the confidence, providing training and tools, we need to do that if we want this to really happen. It doesn't have to be really a full flight of tools. Remembering back to the comment that if we just started by inviting patients into the decision-making process, that would be a big change in the overall care experience. So don't get too lost in all of this, because each journey takes one step to start. So it makes sense to target those patients that you can identify, and that seems obvious, but if you want to target people who are in a decision window, who are thinking about something, and you want to give them the information about that choice, identifying those people who are in the decision window isn't always easy. So you have to go back and forth about who are we targeting, and then how are we going to identify that targeted population. You might want to be thinking about, I'm going to target people who are making a decision where decision aids are available. That's where I'm going to start, because I think these are important tools, and it'll ease the conversation, so that's going to be important. You have to, obviously, to the extent you can, leverage technology and integrate with workflows, and not rely solely on physician memory to prescribe these, because we'll have a very unreliable system if you do that. There are too many competing priorities. I mentioned that if we distribute the decision aids prior to a visit, so pre-visit distribution decompresses the visit and allows for personalized discussions, at least around this topic. And we've seen lots of successful implementations patients this way, if we know who's coming in and why they're coming in. If you do distribute the decision aid and review it in a visit, you can do that with what is now being called short form decision aids. They're not true decision aids in some senses of the word as we described, but they can be simple tables that talk about the options and the pros and the cons. Just a table, a one-sheet table is a start. If you distribute after a visit and you ask the patient to review it afterwards, then you can't just leave them hanging. So there's some sort of follow-up. It could be at the next visit, it could be a follow-up phone call, lots of ways to follow up. Or you don't have to do it related to the visit at all. It can be used as a patient engagement strategy. So we've seen that for patients who are managing chronic conditions, we have registries for diabetes, and there are choices about which of the many things you can do to help your diabetes, using decision aids as an engagement strategy for people who are perhaps uncontrolled and not scheduled for a visit may be an effective use. I mentioned that we need to encourage their use, otherwise there's going to be like the unfulfilled prescriptions for medicine. People need a whiff on what's in it for me. Why is this important? Because you have choices, and because your opinion is important, because things are not quite as black and white as you might think. So if you watch this, and then you come in and talk with me, I think together we'll make a better decision that's best for you. And these are really good tools. This is not like the material that you're going to find on the web where you don't know what the underlying science is that supports it, that it may give you a biased view of one option over the other. So don't go searching all over the web. Let me help you by giving you some information that I know is accurate and not influenced by others' forces. And sometimes the viewing is quite, very little encouragement is needed. Imagine the difference if you're being asked to consider what screening methodology you want for colorectal cancer screening versus what treatment choice you want for a recently diagnosed cancer, where there's more than one reasonable option. Those settings are so totally different from a personal perspective that the latter situation, the patients are very hungry for this information. You've totally changed the experience if you give them good information and the opportunity to talk about it with a trusted source. So the real game changer is supporting the patients during this conversation. There's something that's called the patient response that can help focus the conversation. So new technology is allowing us, once, say, through an electronic health record, a decision aid is prescribed online and the patient interacts with it. You can capture components of that interaction. It can come back into the record, and then somebody on the care team can have a conversation guided by that information with the patient. So, and I mentioned there are decision support approaches, and most people really, most of the clinicians I've worked with like this part of their job. Decision aids help but aren't required. Start by inviting the patient into the conversation, present all the options, and do your best with the pros and cons, even if you don't know the numbers. Do your best to learn them and disclose what you know and what you don't know. And then understanding what's important to the patient as they're considering the options. I mean, this is awakening the curiosity about people that was probably there early in the career for many clinicians, but somehow has been drummed out by the tyranny of these tasks and getting things done. So if we can remain and refine that curiosity and ask how things sound, would that work in your situation, or things like that, we can get a great deal of information from patients, and it's rewarding to us as clinicians. This is hard to read from the back. I apologize, but I put these here so it would be a little bit easier. This is just one example of patient response in an electronic health record. It's about decision, should I get an insulin pump or not? Okay, so that's a decision for somebody. And which way are they leaning? Getting toward getting an insulin pump equally or not getting the pump? And how certain are you about the decision? And then this says, do you understand the options that are available? Are you clear about the benefits and side effects that matter the most? Do you have enough support and advice from others? Are you ready to make a decision? So imagine that somebody is coming in for a follow-up visit with diabetes, and this is a topic that is clinically relevant. You can send this to them in advance of the visit with a message. This would be really important to do for the next visit, because I want to talk at that time about the options of having it or not, and the risks and the benefits. Watch this, and then I have this guide in my record for someone on the care team to review. So that's, before we move into the scenarios, I want to stop, ask the group if they have questions or want to add to the presentation from their own experience or any other comments.
So is a discussion about the cost to the patient of the options available to them? I mean, how do you feel about factoring that in, and how do you implement that?
So the question is, how do I feel about integrating cost into the information about the options? And I actually think it's a really good idea. I think it's hard to do right now, and because of we have not fully explored it. But my sense is to actually have accurate information for the individual patient, and it's their out-of-pocket expense makes it really complex. And what I don't know is if the order of magnitude that we were talking today of $4 times 3, 2, or 1 would be important to the individual patient. If that information was, here is what it costs to the system, here's a relative cost to the healthcare system, and ultimately that is something that is going to be important to all of us. So there may be a way to provide cost information that's not tailored to out-of-pocket that would still be relevant, but I don't think that's been studied yet.
Just on that point, I mean, the Bureau of Insurance indicates that health savings accounts are the dominant insurance plan in Maine. So that means employees have skin in the game pretty much right from the beginning. So I think that's an opportunity that makes them more price sensitive and opens the door to add the element of cost. Because if they're using their HSA, then they'll be wanting to either utilize or wisely use those dollars or not exceed their amount. So I think that recognizes the reality, at least in the private insurance market.
And I think there'll be easier ways to provide linkages to sources of information without having to be the upkeep of that information. So I think it's coming. I hope it's coming. Yes.
My question is kind of linked to hers as well. I guess, so we're talking about cost and how we're lowering cost, but your health insurance plans, some of them are very generous, some of them are not. Some people are very wealthy, some people don't have any insurance at all. How do we, like, are you concerned? Because I know that a lot of people who don't like this phrase shared decision making, they're saying, well, you're going to talk some people into not getting treatment because they don't have money or they're disabled or whatever. What is your viewpoint on how do you separate your, like, because it is an open desire to lower costs, but how do you separate that from not causing the inequality in treatment to become even worse, where we're kind of suggesting to people, well, you don't have a lot of money, so let's look at what your options are here.
Yeah. So the potential for shared decision making, or the use of decision aids to present options that aren't available to a patient because they're not accessible, maybe because they don't have access, or they're not covered by a health plan benefit proposal. And is that a problem? And are we actually increasing some levels of inequality? And my sense is that we would be doing quite the opposite. We would be providing patients with a much fuller view of what their options are, and that they would be empowered to participate in a decision about which one is right for them. And I don't think that I can see any real way that this increases disparity. And there's actually some really good information about people with lower health literacy. And if you take good information is presented around risk and benefit, well, people with lower health literacy learn more than people with high health literacy. You bring them up to the level of the high health literacy. So we are trying to deal with health literacy with the well-constructed decision aids and giving people the full array of their options. And I do not see, but others feel free to comment how this would increase disparities.
So this is the second session, not addressed necessarily, that was staff on shared decision making in the last couple of years. And one of my questions, my first question is, what level of penetration do you think that we have right now where we can say shared decision making has truly been adopted in a system? Do we have any data like that that would suggest what level of adoption we have right now for shared decision making? Because it's not a new concept.
Right.
I saw something of it from 2004, and probably before that, I would imagine.
Yeah, back in the 80s.
So,
Yeah.
Okay, so that's really the first part of my question. And what it then leads to is, if it hasn't been adopted as robustly, why hasn't it, in your view?
Well, I would say that our adoption is very small. I can't fix a percentage. We have a few bright spots. We've worked with some organizations, but they are only the bright spots that we've got to grow. But some significant organizations, like Group Health, now they're interesting because they're staff model. At least part of them are staff model. They also have a health plan, so they're interested in cost. And the culture of who brings the staff model in is different. There's been some of the Kaiser programs. We've worked with small primary care practices in rural Oregon and have helped them, and we've gotten some lift there. It's a big initiative at Mass General, and we're trying to push it across the partner system at Dartmouth and some of the practices at Maine Health that we work with. So I don't want to say it's none, and there's a black box in that. That is, how well has that conversation really occurred? Because that's a hard thing to measure. But what are the barriers? So I'm the first to say we got a long way to go. But remembering, I'm also saying, if we made this something important to do, and we worked on the appropriate incentives, and the patients understood that this was something that would benefit them and needn't be afraid to participate, and we put half the resources, or a fraction of the resources that we do for other quality initiatives, I think we can do it. So I think it's been undervalued from a number of perspectives. So it's a resource issue. I think that the fee-for-service world is a threat. So certainly people are concerned in the specialty arena that fully informed patients, and the literature suggesting we opt for more conservative treatment choices may be a cut in the income. Third, there's these barriers, in terms of persistent paternalism. And it's a whole new, this is a new model. And old models die hard. I mean, look at that, lots of that. So this behavior change goes against the grain of loss of practice, years of practice, and misconceptions that patients don't want to be involved. And then there's a time element to this too. And so I think you can manage it so it's by using the team and some of the decision tools outside of the setting that it's not that much more time. There hasn't been money to pay for access to decision aids. So lots of good reasons why it's been barriers. And the competing priorities, I shouldn't leave those out. There have been so many and so confusing.
Right, I guess just to make a comment, because I'm in a position where I have responsibility for implementing change in our provider network. And there's a menu of opportunities that are kind of laid out for all of us relative to where we think we can make the biggest impact with whether it's utilization reduction or cost savings, however you want to describe it. And for some reason, shared decision making has never kind of elevated to the top of that menu as a real actionable thing. And maybe it's because of the payment model. Like you're kind of suggesting, when I think about operationalizing this, I immediately wonder how would I standardize that in the practices? How we would follow a very formal structure of shared decision making. It becomes very challenging to me when we're struggling with with other things that seem to have a greater return on the investment, whether they do or not, but they seem.
Yeah. Yeah. Well, you know, I think the return on investment is, if we look at that on the short term and we look at surgeries avoided, that's only one way to look at that. If we look at the experience and loyalty that we create by improving the patient experience, that's another way to look at the return on investment. I think the investment, the technology hasn't supported the implementation yet. But the integration into health records is going to make it much easier to do. I think the interaction, the demonstrated interaction of the patient with the decision aid will be a measurable intervention that could be used to administer quality scores or incentives if they're going to do that. I think it will become the CAPS surveys have just changed their questions around shared decision-making as part of the patient experience. So to the extent, this is again incentives, but if an incentive is to have higher CAPS scores that could help. There are a number of others or check-the-box requirements. You have to do this now. So they'll all raise. But the bottom line is that providers think they're already doing it. So why do I have to do it? And those who don't think they're already doing it often believe that patients don't want them. They believe that patients want the providers to make decisions for them. And they're wrong. Yes?
I have a comment and a question. I work in the behavioral health field, and this is not a new concept for the work that we do because they're involved in one, helping us articulate their treatment plan and set goals in their words. So has there been any work done looking at behavioral health care systems in terms of bridging the other way with medicine? Because you're talking about behavior and influencing behavior. So that's just a question.
Yeah, well, I'm aware of some successful implementations in the behavioral health world. And it's interesting because there's misperceptions that many patients who have various kinds of illness and behavioral health illnesses aren't capable of participating in decision making. So that's another bias that gets in the way. And there's a whole series of literature that tries to refute that. And I think there's a subset of providers that are more used to involving patients in medical decisions. I'm not sure if that's true on the behavioral health side or not. You may have to comment on that. But our experience with that is we worked with some nurse practitioner-led clinics, and they were all over it. And that may be a Trojan horse strategy in systems to align with the CNOs or the nurse-led clinic and get them, because they're sick of orders and that whole mentality. And they're all dedicated to patient education. So back to the ego, I think there's an ego thing going on with the docs for some of them. Yes, sure.
I was going to say, maybe are these social workers here by any chance? I feel when you're talking about social work, and I definitely know what I'm talking about as well, but my social worker friends tell me that this is how they create treatment plans. Like they call it something else, I don't know what the something else is, but this is how they're taught to work with, and I don't think they call them patients, I think they're consumers, the clients, clients. This is how they work with clients to implement treatment plans. Like you could never effectively implement a treatment plan in at least social work, I think, view of things, without having this strong relationship with the patient that is a peer relationship. So with my social worker friends at UNE have heard, we've had some discussions about shared decision making, and this is something that it's wonderful that medicine is discovering design social work and other aspects of behavioral health. But I think that's, I hate to speak for them and they're not here, but I think that's what they would say.
I can tell you my job is a social worker.
Okay.
She calls it client contract.
Yeah.
It's the exact description.
We're good. So I've got some validation.
So good. Yeah. So how do we spread that perspective to the physician leaders in organizations. Any thoughts on that would be welcome, along with other questions, because I mean, you have a really good point there. I don't mean in any way to say we got the answer to that. We need to, if this is something we want to get behind, we got to figure out a strategy to build support and diffuse the resistance to it and make it accessible and easy to do through the use of technology. Back. I can't hear you. Could you stand up, please?
Add that bringing the patient perspective to the table is what I do. I think one of the structural things, and you see how they're tied into social work, and also social work is a talking profession. That's what you do. You're expected to talk to the patient for 45 minutes an hour. Whereas medicine is not really one or less than talking profession. I mean, there's 15 minutes and maybe 5 and reduction of talking to the patient. So to me, what makes this so challenging is the lack of talking time. How can you just share decision? It comes about naturally when you spend time to talk to the patient. You get to know one another, you share ideas, you share thoughts, and any skill that you professional, help your professionals would head in that direction. I mean, you can do it. But how do we still have the same time problem? We still have 15-minute visits. So even if you bring in everybody already at the top of their license, you still have 15-minute visits. So how is that to me is the problem. It's not the intention, it's not the intelligence, it's not the skill of the provider, it's the lack of time they have to maybe to truly share decision-making conversations.
Well, I think that's a really good practical point. Do you think that others on the care team aren't able to fill the gap?
Yeah, I'm saying we still have time limitations.
Reimbursement issues.
Whether it's the person working with the person, or I don't know all the correct titles, but it's still limited time.
I'm so glad that Poppy mentioned that. Because I think social work, I'm a physician and I don't have any. But I'm so glad that Poppy mentioned that because mental health has a lot to lend us and so does social work. Those visits tend to be an hour, 45 minutes. My visit is 15 minutes. And I think it's not that other team members can't help or can't work at their highest level. But I think most patients want to make major decisions with their provider. And I wonder whether you looked at if there have been studies that looked at decision aids versus giving the provider an extra 15 or 20 minutes to do shared decision making. Because I am trained in that, but I just made myself wait here by spending 30 minutes extra in shared decision making with a woman who has a monthly problem that gets her in bed for 2 days at a time. So we went through we did shared decision making, but if there's no room for that, then I'm not reimbursed for it, and I make other people wait or not make it. So I wonder, are there studies that look at what if we gave providers 20 minutes extra for shared decision making?
No, I mean, it's a good.
Versus the decision aids.
Right. Well, I don't know that it needs to be versus either, because I don't know that the providers. I think that the decision aids can shorten the visit, and I don't know that the providers will remember the numbers and communicate them in ways that people can understand.
So there's studies that show that they shorten the visits, because it seems to come down to what the patient's really thinking and wondering about, and what they've heard from their neighbor, and what they've read on Dr. G, Google. So I think all of that doesn't come across in my experience, but I'm interested in the research if decision aids really do help us.
Yeah, I think there is research about that. We've had an experience where we've worked with physicians who had patients who had seen decision aids and who didn't see decision aids. Now, this is a real-world study. It's not randomized, controlled trial. But those patients, they judged the visits. The clinicians judged the visits with patients who had had decision aids as generally the same length of time and a higher quality visit. So I think that, like any new skill, it takes a little while to do it efficiently. And I would really suggest that decision aids will make it more feasible.
But have we compared the use of decision aids, which can focus the visit, to giving providers training and the extra 20 minutes to do it?
No, I'm unaware of that study.
Because I think what Poppy said, the time is an issue.
Yeah, there are studies that have scored shared decision making. They did audio tapes with clinicians, and they scored them on objective scales for shared decision making and looked at how the shared decision making score compared to the length of visit. And the best studies showed that it was probably around a 3 or 4 minute differential to score higher. But the overall literature is summarized in a Cochrane review was some shorter, some longer. So there's a look at that, but it does not need to be the hour visit. But if you're comparing it to deciding for your patient, I can't imagine it won't be longer. Right? Yes, please.
So, if we agree it's valuable, and I think we also all agree that providers who've been through training and have established methods of practice are the most difficult to change. Have you had any involvement with training schemes at universities and medical schools, dental schools, whatever, to try and incorporate this as a basic training curriculum in terms of interactions with patients? My first question. The second thing is, how do we deal with the group of patients, particularly the elderly, who just want you to make a decision? That gives me great dilemmas on a daily basis, because I want them to be involved and I want them to try and make a joint decision, and they're just not. Culturally, they just expect me to make a decision for them.
So 2 questions, one around experience with training and the other is the elderly patient or other subgroups who really want you to make the decision for them. Yeah, there's been some effort on the training piece of this and continued interest. So I think in basic medical school curriculum, in maintenance of certification, in maintenance of state licensure, there's interest and ongoing discussion about incorporating this. The concern on the medical school side is if we're not modeling the behavior after medical school, it doesn't last. So we got to be working on both the medical students and also on the residents and faculty. In fact, tomorrow morning I'm meeting with people at Maine Medical Center and Maine Health about a training initiative there. And meeting with the American Board of Internal Medicine to try and do this for our maintenance of certification activity, where we would actually do patient surveys pre and post training to see if the patient's student saw any difference in the nature of the visit. These trainings have been difficult because of we need a scalable approach, and we've worked on an online 90-minute training program that's highly interactive, and it gives you a chance to practice conversations. And we have just piloted that with a group of providers in Washington State and are in the midst of analyzing the provider survey results and patient survey results. So more to come. It's silly to think that it will happen without any training. The question that you ask about what to do with the patient who says, I really want you to make a decision for me. And it's been a long time since I've seen patients, but here's my stock response, and then you can critique me, okay? I say, well, I'm happy to make a recommendation, but before I do that, you have to tell me a little bit more about yourself so I can be sure that the recommendation fits your needs. I really don't care as a shared decision-making advocate. I don't care who tosses the recommendation on the table. That doesn't matter. It's that it's informed by what's important to the patient. Somewhere that gets into the mix. How did that work?
Well, that's kind of how it's evolved in my practice too.
Yeah.
But even asking that question, it's like, well, why would you want to know that?
Yeah.
You're the doctor.
You're God, aren't you?
You got a tough patient there. Yeah. Yeah, and part of the decision aids, some of the decision aids show examples of patients with the same clinical situation making different treatment choices because they're different people. And I might say, well, you know, in my practice, I've had two people in your same clinical situation, and they made very different decisions. And that's why I need to know how you feel about this decision. Mike?
where the carrier payers implemented payment for shared decision. So they, get past this, this is a chance to go over, you actually get an RVD to do insurance.
Yeah. So the question, do we have any examples where payers made some benefit decision in a way that promoted shared decision making?
Well, benefit, not just payment to the physician.
Oh, to the physician for this. Yeah. No. I was racking my brain on it because, we've encouraged people, even the time-based codes are so undervalued now. Why don't you just bill on a 30-minute visit code and say 20% of 20 minutes was spent talking about whether or not to have this particular procedure, this test. But from what I hear, and others who are practicing will correct me, I'm sure, if I'm billing for a 30-minute time-based code, a 99213, I can do two 99213s in 30 minutes that aren't time-based. So I'm not going to do time-based codes. I'm going to lose money doing time-based codes. We don't reimburse providers for spending time with patients. That's why we got this time issue. But this is the group that makes some differences in that.
But if I could just add to this, what is missing from the conversation is what is the return on that investment? Because the power is with everybody here. If you want to do a 30-minute visit, then do a 30-minute visit and have it be all about shared decision making. There's nothing that keeps you from doing that. What does keep you from doing it is the current payment. And that kind of is at the root of the problem here. And so it seems to me that what's missing from this discussion, and it always has been, is what's the return on the investment of, in this case, the provider time or whatever other resources to give you what we think is going to be better informed decisions. And oh, by the way, it also reduces utilization and reduces costs. And I think what I haven't heard up to this point, I'm not saying it isn't out there, I'm just not informed on it, is what is that return on the investment?
Okay, let me go back to that because I think different ways of measuring return. But if we're talking about dollars saved because of high-cost procedures avoided, you could probably talk about the health dialogue paper on that. But and the group health experience. There's some literature there that I'm still feeling is sort of weak because there are confounders that are going to be in there and duration of issues. But more evidence that it improves, it may save costs and improve the quality of care than robotic-assisted surgery, which is out there everywhere right now, and that gets implemented. Why does that get implemented? So I don't know what standard we hold shared decision-making to in terms of return on investment when there's a strong ethical imperative and a patient safety issue and a quality of care initiative. We have to have that save a lot of money as well in order to get behind it. And look what else we're getting behind in the meantime, and what's the value of that? Mike, did you want to make any? Yes, please.
You made reference a few times to other members of the care team we had in the discussion. Can you share what your experience has been in terms of the effective use of other care team members as well?
Yeah. Well, the opportunity to take ownership of getting decision aids to the right person at the right time, and then to follow up on that discussion with that person. Did they understand it? Do they have any questions? Do they need some help in interpreting the information through the lens of what's important to them? Are they ready to decide? And if so, what is the decision? Are they coming to a physician visit? Do you have questions? Can I help you tee up those questions? That sort of stuff. And I've seen a lot of examples of all of that happening.
Did you ever see those situations or processes where another member becomes part of that physician visit?
Yeah. Yeah, there's that's a great question, and I think it's a really unique model, so I haven't talked too much about this, but San Francisco, there's a program that uses students or individuals who graduated from college and are hoping to go to medical school, and now also UC Berkeley students, to help with patients who have breast cancer diagnosis. And they know they're coming in for a visit with their surgical oncologist. And they call them up, they introduce the program to them, they send them a decision aid, they follow up with a conversation, they help them list a question, build a question list, they go to the visit, they audio record the visit, and then afterwards, and if there are unanswered questions, they will prompt the clinician to answer the unanswered questions, and they give the audio recording to the patient. Now, that's at UC San Francisco, and even there, some of the docs are okay with this, and some bristle still about that, but it's now evolved to more than that one setting. Yes?
As far as implementation goes, I've worked with a practice on choosing wisely for the main quality counts. And even though I'm not a primary care physician, I am a physician, but I'm not a primary care physician. The one thing I've learned is that everybody in the practice, if they understand the importance of what you're trying to do, they all kind of understand what we're talking about with shared decision making. They actually help with multiple parts of the process, the targeting the patient, providing the aids, developing the processes. If you just try to introduce it as a lecture or a PowerPoint or something like that, it doesn't get implemented. But if everybody in the practice in their team meetings discuss it, then I have found that they actually have ownership and they think of creative ways to make it work.
That's a refreshing comment. I appreciate that.
It worked,
Yeah.
and they did it. I didn't do it. All I did was go in there and talk about what it meant. Then I go to their meetings and I follow up. But they did all the work, and they actually have made a lot of progress in imaging for low back pain and inappropriate use of antibiotics.
So a similar intervention, but the concept that everybody has to be engaged who touches the project, and they need to be motivated. They have to feel it's important work, and they have to know what the work is to do and how they're going to get it done.
That's
Right.
the problem. If you just deal with a physician, you're never going to get anywhere.
You guys have all been great and engaged with good questions and comments. We have just a couple more minutes. I was going to go through a couple scenarios, but I don't want to do it at this point. I'll show you what I was going to do, so you might just sort of think about it. I was going to give you a couple examples. So a 50-year-old male scheduled for a preventive care visit. Now, who does preventive care visits at age 50? Maybe those are things. Some do, now some don't. So how do you get ready for this? And this would be a good example of pre-visit distribution of a decision aid regarding PSA testing or colorectal cancer screening. And then at the visit, other things are being discussed to have a discussion regarding do you want to be screened and by what methodology. So it's easy. You're not targeting everybody. You're targeting those that are coming in for a preventive care visit. You can do it because you have the type of visit on your calendar. You know when they're coming in. You can send it to them by an email or whatever, snail mail, in advance. You can send a letter that encourages them to do it, and you can have the conversation at the visit. So preventive visits set up a very good time to do screening. We were just going to march through that. And now, this is a 50-year-old woman scheduled for a follow-up visit who has hip osteoarthritis, is being treated on non-steroidals. Now, she comes in and she's having ongoing problems with her hip pain and is wondering what to do next. So that would be an example where you may not have known that she was having ongoing problems. So you can, at the time of that visit, send her with a click, a single click now in the electronic record of decision aid. She can interact with that and then can come back for a follow-up visit. Or if this was something that you were at the encounter were thinking, this may be time to at least consider referral to a surgeon, you could set up a provisional referral, you could call it, send a decision aid and have the patient opt in and say, yes, I've seen this, I do want to go ahead, but thank you for giving me that information. I feel more informed now and have a better idea of what kind of questions to ask. So there are two different models. If you're on the surgical side of this, if you know they're coming in, you can send them in advance or whatever. So you can do this. The hard part would be when you don't know if it's back pain, and you don't know if it's from a herniated disc or not. Or sometimes for prostate cancer, you can't get the patient back into primary care, and the urologist isn't that into shared decision making. So it doesn't really work that great. And that's a problem with the referral system. If we could just say referral for diagnosis only, then send them back to me, and then I'll try to give them some unbiased information about the options. So those were the two things, just to try and make it feel more real and doable. So I thank you for your attention and appreciate your comments. I learned a